lived in Ratham Mill. She loved it.
Wow, that's good. Where did you live when you were here?
I started, I kind of moved all over. We started at Thomas Apartments, and then it was my husband and I, and we were in a super tiny little apartment where the desk was in the bedroom with the TV on the desk.
Yeah.
And I was like, I cannot study here. So they moved me up to Dell's.
Okay.
Just up that big driveway.
Yeah.
And so then we were at Dell's for a little while, and then we moved to Canash Beach, which is where we lived for the rest of the time.
Yes. Yeah, we have a couple of friends who live there at Canash.
It's so nice. And that area is super developed now. Back when I was there, it was just float.
Oh.
There was nothing else. And now, like, they have that restaurant and the coffee shop. The coffee shop was, like, had just opened as I left.
Oh, wow. Mm-hmm. Yeah, there's more stuff now. Like, there's also the, is it the Coconut Grove as well? I don't know if it was there when you were here.
No.
Okay.
And I think they were planning to open, like, a little supermarket store, like a small one in that same building, but I don't know if they ever did.
They actually did. That's the, how do you call it, Brian? By the Café Soleil, the small restaurant in there.
There is a small restaurant. What is it called? I don't know.
Yeah.
My brain's not functioning right now.
Yeah.
Store maybe.
Sorry.
Oh yeah. It's almost like a little gas station, but with like, I don't know, a little bit more. I don't know.
Okay.
But.
Yeah, no, I think definitely, because when were you on the island? Was it like late 2019, 2018?
Oh, way earlier than that. Oh yeah, I was there from 2013 to 2015.
Oh yeah, no, so it definitely probably has changed a lot.
So much, but I'm headed back in September. I'm going to be the white coat speaker for the September class.
Oh, well, that'll be great for some. I mean, I guess like only the people that are doing like welcome committee will get to see you, but well, I'm pretty sure a lot of people will be on the campus for that time. So
yeah, it'll be I'm so excited. It'll be exactly 10 years when I go back.
So it'll be the first time you've been back on the island since you left. Interesting.
Yeah.
How's that feel? Because I feel like for a lot of us here, we're like itching to leave and itching to be like back in the States. But like, I feel like once we do leave, it's like one of those things where I wish I could have enjoyed it a little bit longer.
Yes, 100%. So I was super excited to leave. Also, my husband was too. We kind of knew we would miss it and miss like some things about it, but we were really excited to be closer to family and for me, I'm a huge milk lover, so I was excited to get back to like having real milk that wasn't like $15 for a half gallon that was, crappy and probably expired. And I also love cherry Coke, and they had like no cherry Coke down there. So I survived on Coca-Cola, which was like a very difficult thing for me. So going back and having like a real grocery store and all of those things were really exciting. But pretty much, I would say like, I don't think I missed the island for like 6 months. I was still like walking around Target like, hallelujah, this is like where I belong. My mom literally was like, the first time I walked into Target, she was like, you looked like you were a little kid on Christmas. You were so excited.
Yeah. I completely understand that so much because like I've been on the island for now 6 months. Like I didn't go back home for the last break, but because of that, it just feels like going back into Target, I'm just gonna be like, there's so many things I can buy now.
Yeah, they're not all like almost expired. They're not a ton of money. I don't have to know what day they stock what to get what I need. Like,
exactly.
It's just all there.
Yeah, here you have to make sure you're checking the expiration dates, and even then you might still be like, I don't know if that's 100% true, or the milk, I totally understand. I literally cannot do any milk at this point. Like, I'm just like, we're just not doing it.
Yeah, I couldn't either. I got to the point where I could I could tolerate the boxed milk. And the main thing for me is like when I drink protein powder after I work out, because I eat like a 5-year-old child, like, so I don't get enough protein. So I usually have a protein shake almost every day, and I usually make it with milk instead of water because I think it tastes better. And that was a huge struggle because like not only did they have nothing, so we had to like bring our own protein powder, which we did not know. And so we ended up buying from someone who was leaving the island, and it was like coffee flavored. It was disgusting. Anyway, it was a struggle. And my husband and I were the same. So he came with me to the island, and like a month in, we rescued 4 dogs. One of them is right here on my bed.
Wow.
Oh, you brought that's great.
Wow, that's amazing.
Were you, okay, actually, I have a question. So, were you here when Trinity was partnered with the veteran rescue?
I started that.
Oh, you started? Oh,
wow.
Okay. So we've been trying to get back into doing that, but we've been having a lot of communication stuff. Like things just haven't been working out in terms of timing. So we'll be asking about that at some point then today, because I didn't know that. I did not. We had heard that something like that had been going on here, and we've been trying to restart it, but it's been kind of difficult to say the least.
Yeah, it was amazing. So the first day. Actually, not the first day. My alarm didn't go off the first day of school, so I was late. Whoops. The second day, I set 17 alarms, and I actually got up on time. But the second day, we were on the bus to school I was telling Delphin that I lived at Thomas initially. So on the bus from Thomas to school, I got on when they were still going. I don't even know if y'all still have Ronis, but Ronis was even further away from the school and was closer to the new airport.
Oh, wow.
And so we had to ride from Thomas to that new place, and the driver wanted a drink or something, so we stopped at a little grocery store. Of course, I'm sure nothing about that has changed. The drivers were so funny. They were insane.
They're great.
They're very much the epitome of the island. But we were at this store, and there was a little dog in the parking lot, and I was like, oh, what a cutie, and people were feeding it a chicken bone, and I was like, that's so sweet, they're taking care of this dog. No, they were bribing the dog, and some other guy ran up and kicked it as hard as he could into a cement wall. And so my American white girl just jumped out of this van. I was screaming, I was yelling, I was ready to go to jail. I was so pissed. The bus driver heard the commotion and came out and literally a movie, just one arm threw me back into the van and was like, you can't do that here. And I was like, excuse me? You're telling me I'm wrong? Mm-hmm. And so that day is when I started the VSPCA. And actually that dog was the first, so her mom actually was the first dog that we found, Suki and her babies. She had 8 puppies, 4 were dead, 4 were alive. And they were in the little schoolyard where we were giving a health talk. And all of a sudden this group of young girls got in a fight. I thought they were all huddled around. There was a big commotion. So I go in there trying to break it up, and they're around these puppies. And I see that 4 of them are dead. And I was like, oh my gosh, what's going on? And they're like, oh, we were playing with them. And one picks it up and is ready to toss it like a ball. Because they just didn't know. They had no idea, it's just, whoop, it's not a thing for them. So I actually have pictures of me holding them when we found them. And we took them to the vet that we ended up partnering with. The one of the 3 on the island. I'm sure there are more now, but there were only 3, and it was Dr. Boyle. And so we took them to Dr. Boyle, and he kept them at the vet for 2 weeks because the mom was so sick. She had all the diseases. The puppies were 2 days old. And so my husband and I have Suki and her 3 puppies, and that's one of her puppies, who's going to be 10 in September.
Wow. I mean, that we had been hearing about this, and I'm glad that it just so happened that you were the one that like started this.
Yeah.
But no, I'm glad that you were able to rescue them because like we see there's a bunch of like strays around here. We're told not to like feed them and not to try to, but like it's kind of hard
That's
to like.
My fault.
Oh, it's kind of hard to
feeding all of
be
them.
Like, yeah, no, it's like you kind of just feel bad. It's like I kind of want to help, but like at the same time, like I know they're probably having problems with it. So
yeah, and then I knew someone from the Humane Society in San Francisco, and so they sent someone down to like teach our vets how to spay and neuter cats and dogs with what we had. So we were spaying and neutering dogs with just ketamine, without an anesthesia machine, no breathing tube, nothing. And that's actually how I started to like surgery, was doing those procedures. I actually spayed and neutered that dog right there. Spayed that one, neutered her brother. So that was how I started like suturing and really started enjoying surgery, and kind of was the first clue. Because when I went to med school, I thought I wanted to do dermatology, see one case of lice, and that'll change your mind completely.
You need to stay away from that.
Yeah, no thank you. But that's it's just weird. Like that's one of my dogs right there that I brought from y'all are sitting on.
I know some of my friends are trying to take some of the strays here back home, and I think they now have like an adoption program, which I will be putting in our chat later today. So hopefully someone decides that they want to kind of adopt and take some of the animals that are on here. But we can go ahead and get started. It's
Absolutely.
around 7. People might trickle in, and if not, it's fine. We'll record it and people can watch it later. I know some people did send in questions, so I know people want to know. It's just probably they're busy and have other things to do. But I do want to get started with the fact that how I actually came to know about you, and it's when I was freaking out when I got admitted, or I was coming to the island. I asked Elise about like someone I could talk to about surgery, because that was what I initially was thinking like I wanted to do, and that's how I met. Like she gave me your contact information. I don't know if you remember, but yeah, like it was like three terms ago now, because I'm term 3, so it was right as I was moving in, and I just kind of was freaking out. Of course, moving to a new country, it's kind of freaky. But at that point, you were, I think, transitioning from general surgery into cosmetic plastics. And you were just I was just kind of picking your brain about that. I want to see, like, I know that's my introduction. I want everyone else to kind of get their own introduction about, like, who you are as a person. So if you want to just tell us a little bit about yourself and, like, what you're currently doing.
Sure. So, I guess my journey kind of started at the University of Iowa in undergrad. I knew from a pretty early age I wanted to do medicine, and to be a physician more specifically because of my younger brother. He was autistic and nonverbal and had a lot of struggles, and was pretty much in and out of the hospital a lot when I was young. And so that's kind of my introduction to medicine. And I went to the University of Iowa because I was from there. They're a great program. They're a big medical school, and that's where I wanted to step. And I got to undergrad. My high school was super small. I graduated with 84 people, and then went to the University of Iowa, where there were 484 people in my intro to biochem class. So that was a huge shock, and I didn't do so well in the bigger environment like I thought I would. I was always, homework was never hard. I was smart, and I was top of my class in high school, and things just kind of were easy, and I thought I was just good at school. But I think I underestimated the amount of assistance that a smaller field gave me, and the accountability that provides, that someone knows your face and knows that you're coming to class, knows, your learning type, knows, the kinds of things you're going to struggle with. And so when I was looking for a medical school, I applied for 2 cycles and was denied everywhere I applied. Probably because I was a big dumb idiot and I just applied to like the big state schools because I thought that would be easier to get into. And I was pretty much staying in the Midwest because that was like my safe area. That was the area that I had grown up in and known. And I was kind of scared, honestly, to branch out and to go other places. Lo and behold, they decided to change the MCAT. And so when I took the MCAT, there was a written portion where you got like a letter grade, and they were taking that out. So my MCAT was going to expire as I was attempting my third cycle of applications to medical school. And I was like, I am not going to get any better at physics. So being farther out from it. So I was looking for other options, and I found Trinity. And then ended up at Trinity, met my closest friends there. My husband came with me, as I kind of already said. We literally like got engaged, got married 3.5 weeks after that, and moved to another country 2 weeks after that. So we did a whole lot of life in about 2 months. But it was great. We had an amazing experience. We met our close friends who are still some of my best friends. I'm literally going to see them. They're all kind of in the Atlanta area, which is about a 4-hour drive from me now. So we're planning a weekend to literally have like a big reunion. And those are the same people I met on the island y'all are on right now. But succeeded at Trinity. I did my clerkships actually in Chicago before they started funneling everything to Baltimore and Georgia. And finished that, got a residency spot in general surgery at San Antonio. It was initially a preliminary spot. So a little bit about that is there are preliminary and categorical positions in general surgery residency. The difference is categorical means that you're signed on for the full 5 years of training. Preliminary means that you're signed on for 1 year, and then you have to apply again. And so that's pretty common. Unfortunately, there's also a lot of other reasons that they have preliminary spots. It's for people who aren't sure what they want to do, if they want to do a surgical subspecialty. Some ophthalmology programs require people to do a medicine or a surgery preliminary year. Interventional radiology has to do a surgery or medicine preliminary year. Some more competitive radiology or radiation oncology require a surgery or medicine preliminary year. So there are a lot of reasons. Orthopedic surgeons, urologists, those like more subspecialized things sometimes require, or some people do a general surgery prelim year to make themselves more competitive for those more competitive subspecialties. But it's a hard year. It's very difficult. It's most likely, if you're going from Trinity or any other Caribbean school or any non-allopathic school, any U.S. DO school is the same thing. You'll most likely get a preliminary position. In San Antonio, my year, which it varies every year how many they take, they usually don't really broadcast how many they take because there's usually a little bit of cushion where they can take more or less depending on the structure of the residency. If there are people in research or people funded by the Air Force or the military of some kind, it can change the funding. So don't be surprised if they're not super upfront about how many preliminary positions there are, because it's really in flux all the time because of budgetary stuff, because our government is crazy and doesn't have anything together. But my year, there were 25 preliminary residents and 9 categorical residents. And you can get a preliminary spot for the first and second year. That's an option in surgery. But once you get to the third year position, they want you to get a categorical spot. And there's no switching between residencies between the 4th and 5th year. They want you to complete your 2 kind of chief years at the same place. So there's really no switching once that comes around. If you do have to switch a residency program at that time, you usually have to repeat those 2 years because they want 2 consecutive years to ensure that you've learned everything and you're safe to go out into practice and be a board eligible general surgeon. I'm sorry, that's probably getting into the weeds a little bit, but the main thing is that if you're going for a surgical residency, a preliminary spot is most likely what you're going to get. I would say still shoot for the moon and try for all the categorical spots that you can get, but that's most likely what you're going to be faced with. And so that's just something to sort of prepare yourself for. And it's basically a year-long interview. You are going to be the person that needs to show up early and stay late and, get your work done, keep your head down, and really just be the best resident that you can be, which is what you should do no matter what, right? But it's even more important in this instance because you'll need recommendations from the people that you're working with, and surgery, believe it or not, is a really small world. So my fourth year, when you're deciding to subspecialize, the application process is different for every subspecialty. Some you apply during your fourth year of residency, some you apply during your fifth year of residency. It just depends on what your specialty is. Mine, I was going for plastics and reconstructive, and that's a fourth year application. So that's when that started. Everyone asks me why I chose plastics, why I chose aesthetics. And I think COVID really changed things for me. I realized I didn't really want to work in a hospital. I really wanted to help people, and I wanted people to want to see me and want to have surgery. And I just wanted to make people happy and make them feel better about themselves. And if I can do that with my knife, then that's the best option for me. And so that's sort of how I came to be. It all kind of started when someone was like, oh, you love suturing? You should be a plastic surgeon. And I was like, huh, you're right. That's a great idea. But I ended up in a cosmetic surgery fellowship here in Nashville, which is a 1-year fellowship where you just focus on aesthetics. There's no reconstruction, there's no hand, there's no microvascular. It's solely aesthetics, injectables, breast augmentations, mastopexies, abdominoplasties, brachioplasties, everything under the sun, facelifts, rhinoplasty, blephs, upper and lower blepharoplasty, all of those things are involved in my fellowship that I'm currently doing. So that's me and how I got to be here. And I think...
Yeah, no, I mean, like, that covers, like, that kind of catches everyone up. Yeah, no, I know that when we were initially trying to schedule this, you were just in the process of moving, so I'm assuming that right now you're literally just starting that 1 year now, right?
Yeah, so I started in July, and some specialties, their fellowship will start in July or August. It just kind of depends.
Depends on it, yeah. In terms of, like, how your day-to-day looks like right now, like, what is it, what are we talking about? Like, are you having surgery, like, from morning to night, or is it kind of like you're scheduling certain different surgeries whenever you kind of want to at this point?
That's a great question. So my life now is extremely different from my life as a resident. My life now is I have 4 attendings that I work with, and I look at all of their schedules, and also there are PAs and NPs, nurse injectors, etc., estheticians that I can follow as well. But I look through the schedule and basically see what people have going on. If there's a cool surgery I want to see, I say, hey, I'm going to this. And I just communicate with them and just decide where I want to go for the day. So, for example, my day today didn't start until 11:30 because our surgeries started at noon. And so we did 2 bilateral breast augmentations and a mini abdominoplasty, which is basically just a skin removal, plication of the belly button, but no plication of the rectus, which is really and truly what makes up a full abdominoplasty, is that you make that skin flap all the way up to the costal margin from kind of the inguinal ligament area. And then you tunnel all that up and you basically do a suture all the way down the rectus to plicate that linea alba basically and make it more tight. And then you cut off the excess skin and close the incision. But we just did a small incision, went up to the umbilicus. We took the umbilicus off so that we could float it a little bit, and so it didn't look weird just pulling the skin down. We resutured the umbilicus to the rectus fascia in order to make sure it stayed down and didn't just kind of go crazy. And then cut a little bit of skin and close the incision. And then 2 breast augmentations with implants. One was just below breast tissue, and one was actually below the pectoralis major. So that was my day today. I was done at about 3:30, 4 o'clock. I went and worked out, and here I am. I ate some hummus. It was delicious.
Yeah, no, it seems like a great, like, you're able to, like, choose what you actually want to look at and what you want to see, which is, I think, what a lot of us would probably want to have at some point in our medical career. Yeah. But going back to something where it might not have been like that, what do you think like the first day of residency was? Do you think it's completely different than that?
100%. A 100% difference. So my first day of residency, I started on the most difficult rotation of my residency program, and that was our trauma surgery floor rotation. And I walked in on day one, which was a Sunday, of course. So there were no like mid-levels, no nurse practitioners, no physician assistants, no social workers, no case managers. It was just me and that computer, and we had a battle. So I walked in, and my team, which was based on color, we had 4 teams total, which were based on the chief. Whatever chief was on call, their color would get the patients. So my team had just been on call the prior 24 hours up until, like, was still on call. I arrived at work at 4:15. We were supposed to arrive at 5, but I was nervous. So I got there at 4:15, and I walked in, and the now PGY2 resident was like so ready to be done. She was an orthopedic surgery resident who was just rotating with the general surgery residency because they have to do a couple months of general surgery for their program. And she was like, "Good luck, here's how you print the list." And I was like, great. My list had 42 people that I had to learn. And yeah, my chief was coming. My chief was there because they were still on call, and he wanted to round at 5:30. And I was like, oh, okay. So I'm battling the computer. And at that time, we had an EMR that was even crappier than all of the other EMRs. It was called Sunrise. It was horrible. And things were so convoluted, and I was trying to find information. I didn't know anything. And so we rounded, and my chief was, not moving fast, but his brain was moving faster than I could. So I basically just wrote down every single word that he said as we were rounding, and did my darndest to figure out what he meant and try to do everything I could. There were a lot of questions asked to everyone else who had no idea what was going on. But unfortunately, no matter what you do, this was also after a 2-week-long orientation that the program had given us. No matter what you do, that first day will always be like that. There is nothing that you can do to prepare yourself for the responsibility and the amount of work and the difficulties that you're going to have until you live it, until you do it, until you get thrown into it. And, in some ways, after I was done with my first year of residency, there were a lot of things I did to try to make things easier and better for the next set of interns. And I think as long as you look at it that way and you don't say, which honestly, this is much easier than it sounds, to just say, you know what, I did it, I figured it out, so can you, right? Like, you could say that to the incoming first termers also. Just say, like, yeah, good luck with anatomy. I don't know what they're talking about half the time. Is it still, what was her name? The older lady who chain smokes.
Yeah, I think,
reddish hair.
No, she's not. We had a different experience with anatomy.
Oh my God,
but
we had such
I know a lot of
people
were not fans.
We had such a time. She would go so slow in like the beginning portion that was all super basic, like this is a bone. And then like the important stuff would be at the end when she was running out of time. Yes, the biochem husband and his wife.
Like,
okay, they
Mira's
retired. Yeah. But oh my God. And she had such a thick accent that she would say headache, but it came out like headache. And we were like, what are you saying?
What are you saying?
What is this word? It took us weeks to realize she was saying headache. Anyway, so obviously I've never forgotten. But, it's so easy to say, like, I figured it out. You can figure it out. I'm not going to help you. But looking at it and saying, this is what I've struggled with. This is what I'm going to try to do to make that better. And I tried to do that every month, and just to set up the next interns who are coming on to that rotation better than I was set up on my first day. But that it's crazy. That moment when you're on call, and I was walking the halls just because I was trying to stay awake, honestly, and one of the nurses came running out and was like, doctor, and I'm like looking around, and all of a sudden it hits me like, oh shit, that's me. Okay, yes ma'am, what can I help you with? That moment, there's no way to prepare. If there was, we would be so much better off, but that's why everyone is scared to go to the hospital in July, which they shouldn't be, because like, you're never alone, even if you feel alone. But yeah, it was quite a time. But I showed up at 4:15. We rounded at 5:30. Usually we would show up on a more common day. It would be like you show up at 5 a.m. You usually get report from the overnight intern initially, like, hey, what happened to my patients, anything major? And then you start chart checking and going through whatever your system is to get all the information you need to prepare for rounds. And then we would round anywhere between like 5:45 and 6:30, depending on how many patients were on the list, if there were surgeries that day, because surgery start time at our hospital was 7:30. And a lot of times our hospital was kind of more old school. And I would say that's very common for hospitals in the South to be more old school and resident autonomous. A resident should have been in the room whenever a patient was in the room. And so our chiefs were always trying to get to the operating room by 7:30. And so you knew you were going to lose them at 7:30. Probably a little bit before, because they were going to slurp down some coffee, eat a protein bar, and go to the OR. And you also had to check in with patients, pre-op them, and make sure the consent was signed and their site was marked. So you already would have done all of that before they show up for rounds. And then they would round, and then you would kind of start implementing all of the plans that they gave you, putting in orders, talking to nursing, talking to social work, talking to the patients, telling them, what's going to be happening, what you're doing that day, if it wasn't very clear during rounds, or if something changes. And then you're calling consults. So anytime, for example, a patient had a UTI that we were treating, but now they've developed what we think is pyelonephritis, we're probably going to consult urology and infectious disease, depending on the chief, depending on the day. So you need to call those teams and tell them a brief history of the patient, why you're consulting them, and what you need from them. You're also waiting to hear back whatever their recommendations are, communicating that to your chief and saying, are we going to implement these things? And then you're also writing notes. Your daily note for all the patients really is like the biggest time suck ever, but they need it to bill. So unfortunately, you're stuck. And discharging patients as well. So patients are ready to go home. You go through the entire discharge process. You usually have to discuss things with them if they're going home with a drain, if they have wound care that needs to be taught, if they're going home with Lovenox, for example, they underwent an oncologic resection of colon cancer, and you need to tell them to take 28 days of Lovenox for DVT prophylaxis. Or if a family member comes that you need to explain things to, you need to write all their prescriptions and make sure they have all of those. You need to tell the nurses and the social workers and make sure if they need home health or a PIC line, or if they're going to a facility, that all of that is in order, and then discharge them from the hospital. And then all during that time, you're also possibly getting consults. So people are calling the surgical team, for example, if there's a small bowel obstruction in the ER that your team operated on, that you need to go see in the ER. You have to go see that patient in the ER, make sure they're stable, go tell your chief, run it by them, tell them your plan, and implement all of those things. So those are kind of things that are going on all throughout the day. And then, of course, as little things come up, a patient's pain is worse, you need to go assess and make sure that it's appropriate to give them more pain medicine, or it could be something else. A lab comes back abnormal. You're worried that they might be bleeding. You need to go through your algorithm and either confirm or deny that they are bleeding. And And then you're basically doing that for your 12-hour shift. We had mostly 12-hour shifts with 24-hour on-call. We had a couple of rotations that had a full night call where a different resident would come in at that time and take over for the next 12 hours. It was either that or one of your co-residents on your team stayed for a full 24 and then was there when you got there in the morning to give you your sign out. So it was one of the two. Either a new resident came in at 5 o'clock to relieve you, or one of your cohorts is staying and you're leaving at 5 o'clock. You give them sign out. You say, these are my patients. These are the problems I foresee. These are the treatment options that I would do before calling the chief. But if this happens, I would call the chief. If the consultant gets back to you and says we need to do something, I would check, with the chief if you want to do those tonight, or I'll just take care of it in the morning, etc.
Yeah, no, I mean, it seems like it's a pretty busy schedule. And in terms of that first day, when was the first time that you actually were in an OR, or even just assisting or just doing anything remotely to actually being physically in an OR, I guess?
So my first day, I was pulling drains and pulling chest tubes and pulling the lines. And then my first call day, which was actually the 4th of July on trauma. Yay.
Oh, God.
Yeah. God, it was such a long day / night, but that was the first time I was in the operating room. So day 4 of being a doctor, I was in the operating room doing an appendectomy.
Do you remember what that case was, by chance?
Vividly. It was an appendectomy. It was a 22-year-old male who had classic early acute appendicitis, and it was 2:30 in the morning, and my chief called, and I was like, oh, hi, hello, what happened? What did I miss? And she said, nothing, you're doing great. Do you have a free minute? And I was like, for you, of course, yes. What do you need? What can I do? And she was like, come to OR 11. And I was like, oh, okay, sure, yeah, I'll come. So I show up to OR 11, and she's like, oh, grab your gloves. And I was like, what? Because I had heard, that you weren't going to be in the operating room as an intern. You were going to be a floor monkey. You were going to be stuck doing all the scut work. But she called me down, was like, give your pager to the nurse, give your phone to the nurse, because we still had physical pagers back then, and we had a Cisco phone that they could call also. Mm-hmm. And she was like, give all that to the nurse. You're scrubbing in with me. And I was like, yeah. So I scrubbed in. I did the appy. It was such an easy appy that I made look extremely difficult, because it had been months and months since I had been in an OR. Because during 4th year, towards the end, you kind of want to have a little hiatus. You want to take a little break. You want to spend time with your family because you're not going to see them for a while. So it had been months since I had been in the operating room. And we did some knot tying basic stuff during our orientation, but nothing like laparoscopic skills in the operating room. Mm. But she did not take it from me a single time. I struggled through it. It took me an hour and 35 minutes or something ridiculous. Even the anesthesiologist was like, what is taking so long? This should not be taking this long. But she continued to be like, no, she's learning. She was like my guardian mama, just like, no, yeah. Don't listen, just do it. Keep going. And I got to see him leave as I was leaving the hospital. He was leaving the hospital. And I went up to him and I was like, hi, how are you feeling? I know you barely know me, but I was in your surgery. Are you feeling okay? And he was like, yeah, I feel great. Thank you so much. So grateful. And I was just beaming with pride. It was the greatest moment to see your patient just thank you so much. I feel so much better. Just awesome. Absolutely awesome. And
no, it sounds great.
It was so great. It was I felt like a dumb idiot. I used to say smart brain, dumb hands, because I was struggling with all the technical stuff. But then as it got, further and got better, technically I would say smart and dumb brain, because I felt like I got stupider, but my hands got smarter.
Yeah, it's more of a habit thing at that point. You're just like, oh, I know exactly what's going on. Like, I don't. It's just a muscle memory at that point.
Right, and then you have a med student or an intern being like, "How did you do that? What did you do? Why did you?" And you're like, "I don't know. Why did I do that? I don't know." It worked.
It just happened.
Yeah. Why are you asking me?
Yeah.
But yeah.
Would you say so? It seems like you had a pretty good kind of person as your attendee at the time. Would you say that a lot of the people that were teaching you because from what a lot of people hear is that's going to be a more grueling. You're going to be just put through the mud and dirt when you're in a surgical resident. Do you think that that's the case? Do you think you just got lucky that first time around, or did it completely switch in a different rotation?
It was very rotationally dependent, and I would say that most of my education came from chief residents, from other residents. And if an attending was there, which usually an attending, so again, in the South versus the North, so like my experience with different attendings was different because one of my colorectal attendings trained in Boston. And in Boston, every day the patient has to be seen by the attending. So you would round with the chief and the attending every day. In Texas, at the county hospital in San Antonio, that was not a law. So many, many times, unless you were in the ICU or the transplant floor or something much more serious, you would not see the attending. And so most of my education, especially early on my intern year, because I was on trauma and I was at the VA, most of my education came from chief residents. And those chief residents were either PGY4 or PGY5 year residents. A lot of my education for like the basic day-to-day workflow and EMR stuff and how to discharge people, that came from our mid-level providers, which are like nurse practitioners and physician assistants. So a lot of that came from them because they were there on the floors with us, helping and just making sure there was good cohesion of the teams and no lost communication between us and like social work, case management, etc. So a lot of my education came from that. When I got to different rotations like the ICU, the surgical trauma ICU, we would round with an attending every day. And so you would learn on your rounds with your chief, you would learn on your rounds with your attending, you would also have a PA that was teaching you during that time as well. And then, not shockingly, the nurses would teach you a lot. So I would say my education was very varied depending on the rotation. And there were some rotations that were more chief heavy, more operating room heavy versus like ICU heavy rotations where you're more so placing lines and doing critical care management as opposed to like true OR time. So it definitely varied, and it'll depend on where you train also. My program was probably more of like the old school where it was like you have to learn how to manage the floor before you can get to the operating room. Once you show us that you can manage the floor, then you can come into the operating room. You need to know how to take care of pre-op and post-op patients. You need to make sure you know how to take care of their complications, and then we'll teach you how to do the technical stuff. But being on trauma surgery, I just spent, our trauma department was one of the few, I think it's us, LA County, Baltimore Shock Trauma, and Cook County that still have surgery run trauma units. The rest of them are more ER run. And surgery is just kind of there as an assist, less so like running the trauma. So I would go to our trauma bay where all of the patients would come in and just try to be helpful. And the chief was there, the attending was usually there, depending on how the night was going. And then the students were there, PAs were there. So I would spend a lot of time there. And if my chief went to go to a case and it wasn't too busy, he or she would usually say, "Hey, Allie, why don't you come with me?" And then I would get to go into the operating room. The other thing I did that really helped me get early exposure to the operating room was that I did my notes for the day in the operating room. So I would be sitting in the operating room answering phone calls. I actually had headphones that I would bring similar to these. Initially, they were the plug-in ones, and then the AirPods came out just to, make myself feel old again. But it would allow me to answer the phone while walking and write. That was the biggest thing, was being able to write while you're talking on the phone. So I would be on the phone writing notes, jotting things down, watching the laparoscopic case on the computer here. And then they would say, hey, Allie, why don't you scrub in and we'll close the fascia together. And I would scrub in and we would close the fascia. And then I would get to close the skin. So it's just like being present. You learn a lot. You hear things. You see how people are doing things. And just learning kind of how to be in the operating room is kind of an art. And so just the more time you spend in there, the more face time people have with you, the nurses, the scrub techs, anesthesia, and your own co-residents and attendings. So that was another thing that I did that I think really helped me get early exposure to the operating room and to my attendings.
Yeah, that sounds great. I mean, I feel like for a lot of people, I mean, at least me too, like we just don't know what it's like to be that first day that you're just there, or the first couple months, you just feel like everything is kind of like all over the place. It takes a bit of time before you actually feel like at home, I guess, in a place like that.
Absolutely. And I think your third and fourth year rotations will help with that. Just basic understanding of hospitals, how they work, where you go, what you do, who does what. Just those little basics will take you further than you maybe realize. And then, of course, if anything is unclear or you don't know what to do, you have to know who to ask for help and how to get a hold of them. And I would always try to have a couple people. So in our program, we would have a chief in-house, 2 chiefs in-house at our main hospital every day, 24 hours a day, an ICU chief and a trauma chief. And so I would always, no matter what service I was on, I would always know who those 2 people were, so that if I got in trouble and I needed someone right away, I knew who was awake and in the hospital, who could help me. And so knowing your outlets is going to be one of the most important things. Knowing when to call, basically figuring out when you need help and how best to ask for it and who to ask is the most important thing to learn in the first couple months. If you can figure that out, you'll be okay.
You'll be okay.
Because anything you can't handle, you know who to call.
Mm-hmm. Yeah, I mean, I think it's always just, I think like everyone has, I mean, I've been told you want to just make friends with as many people as possible when you get to that hospital. It's people that you might not think are important, they're just as important as anyone else on that team, because you will never know when you're going to need their help at some point during your time there.
Exactly. It's extreme. I tell all the interns this. It's extremely important early on to get people on your team, because one of my favorite attendings always used to say, you can be as mean as you need to if you have the capital T of truth. But when you're young, you don't know what that is. So you can't be mean. Until you know what the capital T truth is, and until you have enough truth to back you up to be mean, you can't. You are not allowed.
That's great advice, I think.
Yep. And it was good advice. It served me well.
Yeah. I had a quick question. Sorry.
Oh, go ahead.
In terms of the clinical rotations, when you were doing your third year and fourth year, how did you manage your time with shelf exams? And also, did you feel like the clinical rotation on the island helped a lot in terms of kind of giving you a foundation for that?
It's a great question, Dalton. Yes. So being able to be in the hospital on the island was super helpful. Taking those first couple histories is super helpful, because everybody seems to make the same few little mistakes. No matter what you learn, no matter how many times you practice it, until you do it in real time, there's always going to be little pieces that you forget, or little things that you don't know to ask. For example, mine on pediatrics was that a patient had an anaphylactic allergy to penicillin. And I didn't ask if they had ever had to be intubated before because I didn't know.
Yeah, wow.
But so it's just those little things that you don't even know to ask, those little tiny things that you won't know until you do it. You'll be that far ahead of everyone else because you'll have already made those little mistakes and you'll know little tweaks and you'll have little bits of extra information to help you. And I think also being on the island helped me a lot with my history taking because CT scans, when I was there, this may be different, CT scans were like not a thing. If you could not diagnose it with an x-ray, an ultrasound, or a physical exam maneuver, you were guessing.
Yeah.
And even getting an x-ray took a week. So good luck. And half the time the ultrasound didn't work. So you'll get really, really good at getting a history and doing a physical exam and doing those physical exam maneuvers if you really pay attention on the island. Great. And those things will serve you well in your differential diagnosis building and the way you take and present a history to your attendings when you're in clerkships and in residency.
Awesome. Yeah.
I think my first rotation on the island, literally, like my preceptor told me, look, we don't have the equipment here. We have to ask the question. We have to be there doing the physical. We have to do all that because we're not going to have the resources or the technology that you might think you're going to have. So you're going to get good at asking questions. You're going to get good at just physically being there with the patient before you're even going to even see an x-ray machine here. So
yeah. And it's super helpful. It's super helpful. And even in surgery training, we still learn those physical exam maneuvers that you do down there. Obturator sign, Holman sign, all of those things you learn about, and you have to know them for exams, but you will have actually done them. Like, yes. I will never forget what those things are and what they mean for an appendix and all of that because I did it. And those kinds of things will always be helpful. And on step 1, okay, I know this is like a step violation, but I got a chikungunya question. Okay, like you're not going to miss that. You're not going to miss that because of your experience. So don't kind of zone out on those moments. Those will really, really serve you well. And those physicians down there are some of the smartest, best diagnosticians I have ever seen because of those skills that they have to have.
Yeah, no, I totally agree. You brought up the step scores actually, so we'll kind of move into some of the stuff about like application processes and everything that kind of had to do with kind of getting into a general resident. So just starting off, like what I know it might have changed now because like the step is changing, or step changed and has changed and is changing, whatever's happening. What do you think that now with it being pass fail, it's important, or are other things more important? Like where's the standing on that right now?
So I think most people and most programs just assume that step 2 is now going to be step 1 because it's pass fail. So that numerical number for step 2, I think, is going to become much, much, much more important than it was. Because when I was applying, some U.S. graduates who had like killer 270 step 1 scores didn't even take step 2 until after their application was in case they didn't do well, because they had that one number and that was all you needed. I took both because I wanted to show like, this is like my level. This is, I wanted to do well and I wanted to show that was a consistent thing. So that was one thing I did. And I would recommend to you all to plan to take step 2 before your application. Because I think that numerical number is going to become extremely important in your application process. I think it's basically just going to take over the step one. So that's my thought on that. I know a lot of people ask me about research regularly, and I have a lot of friends who are very research minded and do a lot of research papers. I simply don't have that brain. It's just not, it's not my thing. If any of you need a U.S. resident to sponsor anything you want to write, please let me know. I'm happy to look over anything, be part of anything, more than happy to help you with whatever to get your name anywhere. Because it helps you and it helps me. But it's just not something I ever was very good at or really had a mind to do. So I had a couple of things. Mainly I had a couple of case reports that I wrote up during my 3rd and 4th year clerkships. If you have anything cool on the island, that might be a really good case report because people don't see a lot of those diseases or don't see them as progressed as you do in the Caribbean. I remember seeing a terrible case of hydrocephalus when I worked with the World Pediatric Project down there. It was a 6-year-old who had never had a shunt. It was insane. But it's just, you just see things like that down there because of the lack of access to healthcare. But there's a lot of things like that. I had a couple case reports and that was about it. I didn't do any other major research. It probably was kind of a lower portion of my application. But I did some bench research in college that I included a little bit of, but really I didn't have much. And by not having much, I think I had 5 or 6 entries in the research portion of my application. And during residency, I want to say I had maybe 3 papers, 3 or 4, like basic papers, nothing crazy. I didn't do any dedicated research time. There are programs that have dedicated research time. If you're looking to go into something more competitive, surgical oncology pretty much requires it. Pediatric surgery pretty much requires it. It's not written down, but it's basically a requirement. Colorectal surgery is kind of going that way. Plastic surgery is going that way. So it's starting to be more and more competitive for the subspecialties to do research during your residency. And some programs have that opportunity during your residency, some do not.
Okay. So would you say it's a little bit, because I'm also on the same boat. I'm not a big fan of research. I just never was. But do you think it's much more important once you get into residency to start, if you want to specialize, to do research rather than before while you're still in med school? Maybe still do some research, but not prioritize that, kind of prioritize other things that you actually
I think that you're right. That's exactly what I would do. First things first, I would prioritize learning the basics during your 1st and 2nd year, because I still get questions on CYP450 inhibitors and promoters and the pharmacology of all of that. So don't memorize it just to memorize it. Realize that you're building on the foundation of which your entire medical knowledge will be built upon. And you want it to be strong. And you don't want to have just memorized it for your final. You want to know it well enough that your patients can put their life in your hands and you know that you know it. So first thing, I would focus on learning that. I still get micro questions, immunology questions, the complement system still comes up. I got a question on Krebs cycle on the last app site, okay? Like, I'm not kidding. It goes all the way back. So definitely first things first, learn the basics. Don't skip out on it. Don't memorize it. And don't try to be a clinician before you're ready. Second thing, I would focus on passing the step first try. I think that's going to be really, really important. I think if you have to take it again, it's going to be a big negative on your application. Not something that can't be overcome by any means, but just a difficulty. And then definitely focus on step 2. Oh, and Delphin, you asked about time management during 3rd and 4th year clerkships and shelf exams, and I'm so sorry I skipped right over it. So what I did for both step 1 and 2, I actually took a Kaplan course during the time I was in 5th term, because when I was there, our 5th term was still kind of in flux, and they were really trying to find a way to fill that time and really make it valuable. And so I used some of that time to take a Kaplan course. I thought it was super helpful. It was just another way to go through all of the information again, have it be presented to me and written, and, just spending more time focusing on those things. And it really helped me go through the things I hated studying also, immunology. So it was just another way for me to see and hear that information again in a different way. And so that was something that I did. I did the same thing for step 2. I did a Kaplan course again because it worked really well for me on step 1. It was very successful for me both times. I got a 240 on step 1 and a 260 on step 2. So I was very happy with that, and obviously it was enough to get me to succeed. But I think that those courses helped me a lot. It was one of the live but not in person ones. It was the live online Kaplan course. Yeah. And I thought it was really helpful. Only problem with step 2 prep is that it didn't always align with my actual rotation that I was on, which kind of sucked. But seeing the information is never bad. And if you're taking, during your clerkships, if you're doing family medicine first, it's oh my God, how am I going to, that's all of medicine. How am I going to study all that? I don't even know. That was me. So, and then I did pediatrics second, and I was great. So now I have to learn all the same stuff, but for little people. I did, what? So that's what I did. Other things that I did was to try and, I think the hardest thing for step 2 was that there was so much more information, and there were so many more books. Whereas for step 1, it was you get the first aid for step 1, and you get the Kaplan question bank, and then there was one other question bank. There was some really important question bank you always get.
U-World, probably.
U-World.
Yeah.
Yes.
Ambos.
So you got I was always told you get first aid and you get U-World, and you do those to the death, and that's step 1. And then I got to step 2, and it was well, you could use step up to medicine, you could use first aid, you could use this, you could use this. There were 6 books that people were these are all helpful, and they're all cumulative. And I tried to learn them all, and it was too much. And so I think my best advice for step 2 is, again, U-World was super helpful. Again, the Kaplan course is really helpful, and the Kaplan question bank comes with that. I think the most important thing for any big test prep is questions. There's no other way to know how you're going to handle that. And I actually did a couple of days where I would do a full-on practice. I would do the 9 hours, time myself with the breaks, with the snacks, that I was going to have that day to really prepare your mind for that kind of marathon. And I thought that was really helpful also, because it's so different than everything else you've had to do.
Yes.
Yeah, no.
In terms of question, was also the same way when you were on the island, for your 2 years? Did you do a lot of question, kind of to get through the 2 years? Okay. Great.
Yes, I did a lot of questions. I sort of tried to use the Kaplan questions early, and then I saved the U-World questions for when I was really prepping for step 1. And I did the same thing for step 2. I used the Kaplan questions when I was studying for the shelf. When I was doing it, and this may have changed, but when I was doing it, the Kaplan questions were always a little bit more detailed, a little bit more nuanced, and smaller details were more important. And so I felt that was better for pediatrics or physiology. It was more geared to that kind of learning, at least for me. And then U-World was more kind of cumulative, putting everything together, kind of thought process that the step was for me.
Awesome. Yeah.
Yeah, so I think term 4s might have a better understanding of this, but I think term 5 now is having an actual Kaplan course that they're kind of being put through. They just implemented this last term, or they were this last term or so they were implementing it, and I think next term it'll probably be a little bit more kind of. They finally
got my comment card.
Yeah, it seems so. It seems like somebody has been really asking for it. So I think they finally decided to kind of do that for at least step one. I don't know if that's going to be the same for step two, but at least for step one, there might be some sort of course that you're going to be taking during your term 5. So
I thought it was super helpful, and it's not cheap even for the step 2, but at this point you're spending $2,000 to take a freaking test. I mean, whatever. Just like money is monopoly money for you right now, and it still is for me, to be quite frank. Like, I just took my general surgery board, and the test was $2,500. I mean, what is that? I don't even know. And that's half. Like, that was just the written. I have to take the orals, which is like $3,000, and then that's not to mention licensing fees. Right now, I hate to say this, don't tell your parents, don't tell your loan co-signers, but money is monopoly money. Just like do what's best for you and just like take out an extra loan, because it's not worth it to save a couple grand in the grand scheme of like a $300,000 debt. Like, just. I mean,
we want to get through rather than be in debt and then not have any way to deal with
it. And you want to be successful. You want to have a residency. You want to do those things. So just pay the money.
I think someone actually asked, like, during that first year, how much are you actually getting paid? Because I mean, we've heard ranges from like 50,000 a year to 60, 70. So I don't know how it was.
That's about right. It slightly depends on where you live. So like obviously they're making more money in New York City because it costs more to live there. But that kind of 50 to 70 range is about right for residency and for fellowship. So for me and my loans, I refinanced and got one of the refinancing options that has you pay like $100 a month during your training, and it like decreases the interest rate during that time also, and then you start repaying once you get like what I keep calling a big girl job. Then you start repaying and the interest kind of bumps up a little bit. So that's probably something that you'll have to look into in the future, because you make barely enough to live, and you're working 80 hours a week, which is, there are 160 hours in a week. So I did that math and regretted it. So now I tell everyone.
Don't do it.
Yeah, don't do the math.
Don't do it.
But yeah, so it's not a lot, but better than going further and further in the red.
Yeah, that's true. We'll kind of try to close out a bit, but I think a couple people were wondering, like, what is the thing, like, were you researching different schools? Because, like, as coming from an IMG, I mean, you hate to say it, but you are looked at a little bit differently when that shows up on an application. So were you doing research on, like, which schools are IMG friendly, or which ones weren't? Or, like, was that really a consideration? Were you just applying to places and hoping for the best? Or just throwing your net as wide as possible? Like,
so I did a little bit of all those things. So my first application process, I did a ton of research, and I used the Frida research thing. I'm not sure if that's still a thing, but it basically just like, I went to like the demographic portion of the Frida website for each, and it basically would tell you like their minimum step requirement, which was always BS. It was like passing, which you're like, okay, that can't be real. But anyway, and then it would break down like females versus males, IMGs versus US graduates, MDs versus COs, and anything with like a semi-favorable grouping, I would apply to. Anything with a preliminary position, I would apply to both categorical and preliminary. There was a rumor going around my year, and I don't know like where it came from, but it's BS, that you don't want to apply to both the prelim and the categorical position wherever you're applying. That is fake news. Apply to both. Don't stress about it. Nobody cares about it. Just apply to both. It doesn't cost you anything extra to apply to both. That was also another rumor going around, but that was fake news. So click both. I applied to a total of 150 programs, and I think there were like 330 total. So I applied to about half. There were some that I was like, I know this is a long shot, but I'm applying, whatever. There were some that were like, wow, I really don't think I want to go here, but they take more IMGs than US, so I'm going to apply here because I think I have a good chance of getting at least an interview. And then there were some that, you know, I was just like, well, I know that name, so I'm going to click it. Maybe it's not the best strategy, but I applied to 140 general surgery programs and 10 transitional year programs. And the reason I applied to the 10 transitional year was because our late dean, Paula Wilson, was very adamant about applying, if you were applying to something more competitive, like surgery, was adamant about applying to a secondary specialty. And I was equally as adamant that I would not be happy doing anything but surgery. So she convinced me to apply to 10 transitional year programs. And that was all I would give her. And my God, was it stressful. But I got 10 interviews and I ranked all places but one. And the reason I didn't rank the one was because it was in New York City, in the Bronx. And the program had some red flags. And I had 4 dogs and a husband that likes a yard. So I couldn't do it with like cost of living, with the hospital having the red flags that it did, the residency program having the red flags that it did. I didn't even rank it. And Paula, again, was very mad at me about it. But I sort of stuck to my guns on that one, and I'm pretty happy that I did, because it would have been miserable, and I would not have been successful. So I would say, do your research. It's important. Anywhere that has taken a Trinity student before, I would apply. And I would reach out to that student and say, hey, you know, I'm applying here. And this goes for any specialty, anything. You know, like, hey, I'm applying here. Just wanted to let you know I'm from Trinity. Like, do you know anyone in the department? Do you, like, anything? Because all of the alumni, all the people that I know from our school are all about pulling y'all up to follow up. And I know that I've been contacted by Trinity students applying at San Antonio in family medicine, in pathology, in everything. And, you know, all the program coordinators know each other. So if there's a shoe-in, take it. Don't be too prideful to not reach out, because it may be the difference. The other thing that I did during the application that was a little bit different was that I actually went to the American College of Surgeons Clinical Congress, which is their annual meeting. And there is like a med student portion of the program that you can attend, which I did. It's only like 2 or 3 days, but it's basically like interview tactics. And there's actually like a meet and greet with program directors, which is, of course, like everyone trying to put their best foot forward. It's actually a really difficult time to get FaceTime with them. And everyone's trying to ask like the best question to be remembered. But if you stay for the next couple days where they're actually doing their regular meetings and their other kind of forums and stuff, that's where you really meet people. And they'll introduce them and they'll say like, this is so-and-so. And that's how I met my now program director. I met him at Clinical Congress, and went up to talk to him after a forum and basically just said, you know, I'm applying this cycle. I really enjoyed your talk. It was about keeping the general surgeons general as opposed to like super subspecializing everyone and like kind of more rural medicine. And, you know, I did what I do and I spun it for an interview. I was basically like, you know, I'm from the Midwest. I'm from a rural area. Rural medicine is something I'm really passionate about. Baloney. Whatever. But, you know, I was really, you know, it was great talking to you, and, you know, I would love to have the chance to interview with you because I think your program would be great for me and I would do really well there. And that's all it took. I got an interview offer the next couple of days and it's where I ended up. So that's another thing. And it was in San Diego, which is like one of my top 5 favorite cities in the world. So it was absolutely beautiful. It was great to go. And it doesn't cost anything to actually go as a medical